Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. I'm also a professor of global health at the Rollins School of Public Health in Emory University, and also have a position at the National Cancer Institute of NIH. And it's my pleasure to welcome you to this edition of our webinar series to highlight NIH extramural and intramural research related to putting innovative progress toward hepatitis elimination in the US and globally. Today, as you can see, we will be examining racial and ethnic disparities in health related to hepatitis elimination. And this webinar will be convened and moderated by the National Institute on Minority Health and Health Disparities. As I mentioned, this is part of a series. We have 8 previous webinars. All of the webinar information is available on the Coalition website at globalhep.org, and that includes the video recordings of the webinar in full, videos of each presentation, the slide sets, and a synthesis report to provide an overview of the content so that help you find the information you're looking for in the future. Next slide, please. I want to thank the organizing committee that brings this webinar together. My co-chair, Betsy Reed-Conley at NCI, and the other members representing many of the institute and offices at NIH as shown here, and in addition to colleagues at the US CDC. So today, as I mentioned, this is from NIMHD. This is the agenda of the speakers that you'll be hearing from and the topics that they'll be addressing to look at different aspects of racial and ethnic disparities related to viral hepatitis, particularly hepatitis B and hepatitis C. We very much want this to be interactive, so please put your comments and questions in the chat of this Zoom platform. We will ask the speakers to respond to questions that are seeking to clarify different topic area, different aspects of their presentations. And then we will also be seeking to capture larger cross-cutting questions that we will seek to put into the discussion for all the speakers to respond to as appropriate at the completion of the 3 presentations. I think now I'll turn it over to my colleague, Dr. Rena Das, who's the Scientific Program Director, Division of Integrative Biological and Behavioral Sciences at NIMHD. Rena?
Thank you, John. I'd like to welcome everybody to participate in this webinar series, Leaving No One Behind, Culture and Context Counts in Tailoring Hepatitis Interventions. So at NIMHD, we are interested in health disparity in all diseases, but specifically in liver diseases, understanding the causes and trying to intervene to reduce these disparities. Last year, we had a webinar series on understanding the causes, what drives these disparities. So this year, we thought that we want to invite researchers who are working with various racial ethnic communities focusing on intervention research, how to address these health disparities. So they will be highlighting their research on how to tailor interventions, how to consider context and cultural factors for each of these communities as we go about trying to eliminate health disparity, hepatitis disparities. So for today's session, we have 3 great speakers and a panelist as listed on the slide. We have Dr. Perumal Swamy, who's going to be focusing on immigrant African communities and other underserved population. We have Dr. So, who's going to be focusing on Asian communities. And we have Dr. Turner, who's going to be focusing on low socioeconomic status, and Latino populations. And then we have our panelists, Dr. Falade Wulia, who's going to be leading the panel discussions. So to start us off, it's my great pleasure to introduce Dr. Persist for opening remarks. He's the director of the National Institute on Minority Health and Health Disparities. Before joining NIMHD, he practiced general medicine, internal medicine for 37 years at the University of California, San Francisco, and he has been very supportive on these efforts on liver disease disparities research. Dr. Persist.
Thank you, Rena, and thank you much, John, for leading the charge. I'm going to be brief, both in terms of welcoming and hopefully setting the stage. I was asked to, I can't get this, hang on. There we go. I get rid of that slideshow. Here we go. All right, so hopefully those are visible to everyone. And spend a few minutes reviewing some of the data and highlighting what I think are some of the issues, the big picture issues we need to hopefully focus on through our research. So I'll start with just a quick summary of how we see things at NIMHD. You know, how do we do science to reduce inequities? This applies across the board for all conditions. Hepatitis, liver disease are no exception. You know, standardized measures, big data science, big data capacity, discovery science is really important there. We need to have diverse workforce. That's a huge gap that we need to continue to push on. We need to continue to cultivate community engagement if we want change over time, and this requires building sustainable trusting relationships. And then we need to implement what we know, and we are falling short on that in many areas, including hepatitis prevention. Everyone, hopefully in this audience, knows our populations with health disparities are listed at the top 4 bullets. We embrace the idea that all of these populations share this common theme of having a social disadvantage resulting from being subject to discrimination or racism and being underserved in healthcare. And then a health outcome that is worse is what we call a disparity in some comparison group or some metric of standard ideal health. There are many reasons why measuring race and ethnicity and socioeconomic status as really parallel pillars in the science that we fund and foster are important to measure in everything that we do with humans, because there's so many things that they matter and that we don't understand why, that we should measure and consider before we discard them as explanatory associations or factors. Predict life expectancy, mortality. We see more strokes in African Americans compared to whites in an observational cohort study for the exact same level of systolic blood pressure. There's more chronic disease in people who are poor, and many of these are related to structural factors. And then even within a diagnosis such as diabetes, we see differential outcomes related to heart disease and end-stage renal disease, influenced by your self-identified race ethnicity. Again, direct the audience to our research framework developed by staff a number of years ago to capture this complex dimensions, levels of influence and domains of influence that affect us. Most of the research we still fund is here in this first column, individual. We do think a lot about community and societal, but the funding trails down as we go from left to right. And if you ask me about a causal direction of disparities, it's probably more in the right to left direction than the other way. So this is just as background. So what do I think are the most important things in hepatitis, chronic liver disease, and liver cancer? And these are not different from last year, I think, for the most part. So, you know, first and foremost, hepatitis B is preventable with a very effective vaccine that we've had now for, I think, I'm going to lose count here, but probably around 40 years. If you look at the experience in Taiwan, they have had a big impact on the rates of liver cancer because they implemented and successfully implemented hepatitis B vaccine broadly. The US picked up in the early 90s with universal vaccination, but as you will see, we're far behind in getting universal acceptance or uptake. And we've been there with COVID, so we know that this is an issue. Hepatitis C is curable for the most part, not entirely, but most of the phenotypes seen in the United States can be treated with a regimen of 8 to 12 weeks and get 90–95% cure. So this is something that wasn't even dreamed of 10–15 years ago. And now we've seen already an impact on liver transplants related to hepatitis C going down. So again, we have the tools, it's implementation that is needed. There's a lot of evidence that causal pathway to liver cancer and chronic liver disease includes inflammatory conditions and fatty inflammation being one of the main ones leading to chronic liver disease and cirrhosis. Of course, hepatitis B and C can do this even in a quiescent way. And then aflatoxins are also potentially having a role, particularly on the border in the Mexican-American Latino population. Liver cancer is increasing predominantly only in American Indian, Alaska Native populations. But as you will see, it is, well, I don't think I show the data, it is much more common in men than in women. It is much more common in all of the racial and ethnic groups across the US compared to whites, the minority groups. And we're seeing the disproportionate effect. There's different etiologies. So hepatitis B has been the predominant cause among Asian Americans and Pacific Islanders. It is not the predominant etiology among Latinos, but hepatitis C may be more of a role in African Americans and so forth. So I think this needs data on local and regional data is going to be important, and then targeted screening and early treatment of the small population of women who are pregnant who have chronic hepatitis B, predominantly immigrants from Africa and other high prevalence low income and middle income countries, not Latin America necessarily, but mostly East Asia and Africa and sub-Saharan Africa. We can control this if we identify, treat appropriately, and immunize the family. Quickly show some data. This is thank you for the NMHD staff that pull these slides together, and in Rena's division. We see this rate of hepatitis B prevalence predominantly seen in this Asian/Pacific Islander group. And in this case, the effects of the condition are in the similar direction. That we've made progress here, which we haven't in the other groups, more in African Americans as well. And again, we see the male more likely and the urban population more likely. Vaccination uptake is pretty bad. If you look at it, any way you look at this, oh yeah, the Latinos are the worst at 27%, but the best group, even if it's 40%, we're still looking at a very low level of immunity. And when we started out with Hep B, it was like all these risk groups and targets and stuff, and that probably confused the community more than anything. Universal vaccination in children, in newborns is important, and if not, immunizing adolescents pre-adolescence, so at the 9, 10, 11-year-old group. But we really have to make this a much bigger emphasis. It's a safe, effective vaccine that probably has, I don't want to say lifetime immunity, but very, very close to that. There are rarely any reported cases of someone developing acute hepatitis B after they've had the full range of hepatitis B vaccination and had a good antibody response. In terms of hepatitis C prevalence, we have a better handle on the epidemiology of this, and what stands out from the data available from the CDC here is the American Indian Alaska Native population just really at much higher risk. Again, a male predominance here because of the American Indian. In part, you see more of a rural predominance. Transmission is not always so clear. Probably similar to B. although the level of infectivity may not be at the same level. And then you don't see, let's say, the Hispanic population, which I'm more familiar with, Latinos, based on the Seoul study, Puerto Ricans had a higher rate of hepatitis C exposure, but not the Mexicans and not the Cubans or Dominicans or South Americans who were in that cohort study. So you do see differential epidemiology here across the board, but it stands out again, American Indians, Alaska Natives, disproportionately affected. And overall liver disease, again, overall rates are low. You see high rates, the highest rates for Mexican or Mexican Americans. But again, the absolute rates are low. And it is primarily an effect of the multiple components contributing to chronic liver disease. Again, fatty liver inflammation consequences, not fat itself may not do it, but just the inflammation that follows. This is chronic liver disease mortality. American Indian, Alaska Natives up here. And then you see the other groups with the Latinos being second and whites next. And then you see some other groups sort of clustered down here at the bottom with an increase now in Native Hawaiians. We're finally getting some data clear cut across the board on Native Hawaiian Pacific Islanders separate from Asians. And it's so critical to do that given the fact that their outcomes are different in many, many conditions. CDC has, this has been a standard from the CDC, National Center for Health Statistics, since the year 2000. It just took all these years for the states to come along and start reporting it differently. So we always blame the federal agency, but it really was the states that dragged their feet on this, especially for the death certificate categories. And liver cancer, again, not separated by sex, which if we would, we'd see it's 3 times more common in men. And again, see this increase in American Indian, Alaska Native. It's the only group where we're seeing it go up. It has sort of flattened or started to come down among Latino Hispanics and has generally come down for Asians, Pacific Islanders. I'd like to think this is an effect of hepatitis B vaccination uptake, since this population was targeted initially more, given the immigrant population coming from high prevalence countries. And again, we could do a lot more here if we implemented vaccine and treated hepatitis C. I mean, it wouldn't eradicate it, but it would certainly get a handle on it. And liver cancer is now, it's either 5th cause of liver cancer mortality, or cancer mortality among men, and it's right not far behind for women. And these are the mortality data that parallel the incidence data that I showed you. NIMHD and NCI did have a funding opportunity announcement in this topic. In 2017, we received about 100 applications. 12 grants were funded, so that's about average for our ICs in terms of awards success rate. Some of the sample topics are listed here. Mechanisms of, let's say, non-alcoholic fatty liver disease, community approach to improve hepatitis B screening in a targeted population of West Africans, and looking at multi-level factors for hepatocellular cancer. We continue this, and so we welcome these applications, and I think NIAAA was also signed on to this, but none of the applications signed to them were funded. So thank you for your attention, and love to hear what we came here for, the scientific seminar presentations.
Thank you. Thank you, Dr. Perez-Table, for that wonderful comprehensive overview. So let's move on to the first speaker today, Dr. Poni Perumal-Swamy. She's an associate professor of medicine at University of Michigan and at the Ann Arbor VA healthcare system and health services researcher. She's focused on improving access to care for patients with liver disease. She'll present on community-based interventions to address health disparities and advance hepatitis elimination. Dr. Perumal-Swamy, take it away.
All right, thank you so much, Dr. Das and Dr. Ward, and the rest of the organizers for the invitation to share a little bit about work on behalf of our group. My talk today is entitled Community-Based Interventions to Address Health Disparities and Advance Hepatitis Elimination. So I hope to touch on some of the principles that I have found very useful in community-based work, and also share a little bit about how it came down the path that I've gone. I don't have any disclosures, and I think, as we just heard from Dr. Perez-Stable, we certainly have the tools. And so I think the question still remains, why haven't we solved the public health issues around hepatitis B and C? We certainly, as you just heard, know how to prevent, diagnose, and treat, but not everyone has been reached, and disparities exist. Stigma and discrimination, unfortunately, remain big problems, and so gaps remain. And there are a number of evidence-based community interventions that you're going to hear from myself and the other panelists and speakers around testing linked to care, treatment, and how we do this in different settings. And I think one of the principles I'd like to start and also leave the audience here with is this concept of what still needs to be done. I would argue we still need to continue to advocate for increased funding for research and programs and activities, and to continue to engage our communities and think about how we implement and study implementation and then scale our interventions. My part of this talk today is really going to focus my work around hepatitis B with our community partners. I'm a hepatologist. I'm not married to any one virus here when we're talking about viral hepatitis. But we know that there are a lot of disparities, as you just again heard, and that the majority of Hep B infection in the United States is really shouldered in our foreign-born populations. And we've certainly seen a rise over the last several years in the number of Hep B cases, particularly in people with opioid use disorder, and that a lot of the disparities, again, have to do with stigma, discrimination, a lack of awareness and education, thinking about health-seeking behavior and how this is different in the communities that remain at risk. And what I mean by that is, some communities certainly are driven around prevention and symptom-driven behaviors in terms of when they seek help. Versus other communities, it's really only symptom driven. And we know that with these viruses that are largely asymptomatic, that by the time symptoms do develop, if they're related to this disease, it usually means that the disease is quite advanced and our treatment and care options become much more limited. We want to get the patients earlier. And certainly another barrier that still exists include those surrounding access to care. And that might include things like a lack of insurance, language barriers, health literacy, and transportation. A lot of my work has focused on hardly reached populations when I think about viral hepatitis and thinking about how we scale up testing linked to care and engagement in these groups. I do think that language matters, and for, I would say, quite a long time, too long of a time, we've often described our communities that are at highest risk for these viruses often as terms like difficult to engage, hard to reach, special populations, which I think only adds to stigma and creating barriers. And thinking about how we scale these activities within communities and build ties and develop relationships that are bidirectional, and think about how we do a better job of breaking down silos and integrating care. So with that in mind, really my activities in the viral hepatitis space certainly have been focused on how do we increase provider capacity, particularly on the frontline provider capacity to reach people living with viral hepatitis, and how do we identify the determinants to viral hepatitis screening and care, and really focus on redesigning and focusing our solutions to barriers at the system and provider level. I come back to this framework quite often. It was developed by the CDC along with a number of other institutes and programs, and this is the continuum of community engagement. And what you can see on the left side are what I would say probably lower levels of community engagement, and that really thinking about, for myself, it's been very helpful to think about this framework and how I continue to push what we're doing towards the right. On this figure. So really push it towards collaboration and shared leadership. And I think in order to have a wider impact and developing deeper ties to communities, this has really been a nice framework to really try to embody in the work that we're trying to build, because this enables bidirectional relationship, really helps build trust, and really build deep ties to the communities that we're trying to reach and serve. The evidence-based intervention that I have focused, my activities around have been around community health worker-led models of viral hepatitis outreach. We know that there's been really just an explosion or growth of evidence around community health worker-led models of care. And, thinking about public health workers or community health workers trained in this way to really bridge the gaps between health systems and communities has been helpful. And we know that the evidence is quite strong in terms of systematic reviews, thinking about chronic disease management and strength of evidence in randomized controlled trial, and some limited work also, as we've discussed, in terms of a lot of our foreign-born populations. There was a nice systematic review published several years ago looking at this model of care in API communities or Asian American Pacific Islander communities. And the top 3 diseases included cancer, cardiovascular disease, and hepatitis B. But there still are a number of communities, I would say, that where this model has yet to be leveraged or has been leveraged in a very limited way, which was really kind of the kernel or the proof of principle when I first started thinking about how to develop a community-based viral hepatitis outreach model back in 2009, which we later called Hepatitis Outreach Network. So thinking about how we train and recruit community health workers to really help us develop these models, to engage community partners, particularly our foreign-born communities that are at risk of viral hepatitis, and engage our partners, implement navigation strategies, offer education, testing, and link to care, and have a community health worker embedded in all of those activities. And in the first 2 years of this outreach, viral hepatitis outreach model, we were certainly able to find and not only just test a lot of people for hepatitis B and C, but find people with living with chronic infection who had not yet been diagnosed, and get more than half of them into care and most of them into and onto treatment, along with kind of long-term management. And so doing this work, certainly focused a lot of attention when I was living in New York City in our Asian American communities, but did this in a variety of different foreign-born communities, and found within the African-born communities, we found more than 8% with undiagnosed chronic Hep B infection. So we know that certainly HCC is a major cause of premature death in Africa. Viral hepatitis is the dominant risk factor for HCC in African nations, and that 23% of all individuals with Hep B infection globally reside in Africa. And certainly at the time when we were starting this, we had a lot of groups engaged in the Asian American space, not many groups really engaged in our African communities, where there's quite a large population in the New York City area. And thinking about the growth of this community over time, and how many people who had not yet been diagnosed, really in my mind said that there was still a gap that we needed to try to address. And most recently, this is data that came out of the Pew Research Center. We now know that 1 in 10 Black people living in the United States are immigrants, and that this has really increased over time. We have more than 4.6 million Black immigrant population residing in the United States, which is projected to double by 2060. And the percent of US Black population who are foreign-born has grown from 3% in 1980 to above 10% as of 2019. And there's certainly a lot of differences among Black immigrants. Those born in Africa tend to have lived in the United States for a shorter period of time compared to Caribbean, Central America, or Mexican or South American Black immigrants. And you can see how graduate level education and medium household income kind of falls in between what we see with general US immigrants and US born Black populations. So thinking about, again, a gap in these communities at the time when we started, really shifted our focus from working in Asian American and other communities to really trying to do additional work in the African-born communities living in and around New York City. So with the help of a really wonderful community health worker that was recruited to work in this project, and a wonderful relationship with the community partner, African Services Committee, we were able to really focus more efforts in trying to reach the West African diaspora living in the New York City area, test them, get them into care. So really, again, highlighting how community health worker led a model of viral hepatitis outreach could be effective in this community. And we were able to find quite a bit of, again, undiagnosed Hep B infection in these communities. So in developing and thinking about how to build and expand strategies, it's been really helpful for me to think about implementation science and the strategies that can enable community-based intervention. So there's a wonderful publication from 2015 by Powell and colleagues that is often referred to as the ERIC taxonomy of implementation science strategies. There's 70 plus implementation science strategies. I actually went back to that article to kind of look at all of the different implementation strategies that have certainly spoken to me in the work that I've been engaged with community partners. And these implementation strategies include things like building a coalition, creating new clinical teams, developing academic community partnerships, changing service sites, conducting community educational outreach and educational meetings, and creating new clinical teams that might integrate peer navigators and community health workers into those teams, and developing educational materials to advance what we are doing. And thinking about the implementation science approach really has to do with thinking about how we engage stakeholders deeply, and these stakeholders can be at the community member level, community leader level, health provider and health system levels, and then map determinants to implementation strategies, and then adapt or develop models of care from a health disparity standpoint, pilot test strategies, evaluate them, and then kind of go from there. And then we really want to think about what we've done in the African community, and certainly some of the formative work was in identifying barriers around what was happening in the West African community as it relates to hepatitis B, and understanding that barriers when we did this work had to do with limited Hep B knowledge, stigma, fear of disclosure, health-seeking behavior really being symptom-driven rather than preventive, thinking about language barriers, and then trying to think about strategies to overcome these barriers, including developing educational tools, reassurance around disclosure of test results, and preferred understanding what preferred languages and English proficiency look like, and involving community leaders, I would say, was a really important piece of this. So in terms of kind of coming up with an implementation intervention plan, I had the determinants kind of mapped out on the left, and then trying to map them into implementation strategies on the right. I think one of the key components of our implementation strategies that's been very effective in building ties to the West African community certainly has been in developing and establishing a community advisory panel. And these are leaders from the West African diaspora in the New York City area. We meet 2 to 4 times a year. COVID has made us think about more creative strategies, and virtual technology has enabled us to continue these meetings. But really thinking about how we collaborate and share leadership, how we create bi-directional communication and activities, how we solicit feedback and advice, and then really sit together and think about what direction do we want to go in together, how do we develop study ideas and integrate activities better, and then also think about how community leaders can be involved with recruitment of the participants we're trying to reach, and be participants in what we're trying to do. So the current grant specific aims that we have ongoing include a test the association of sociocultural factors in West Africans with positive views on Hep screening and intent to undergo screening, with the idea that we take this information and then we develop and refine a group Hep B education program that will then be pilot tested in AIM 3 in the West African communities. To assess acceptability and feasibility. We've also incorporated a behavioral theory-informed approach in community-based participatory research. Here we've used the theory of planned behavior to try to understand what are the domains of influence really around attitudes, knowledge, and perceptions around self-efficacy, to understand what then drives intent and eventually screening. And I know we just looked at this slide, but I think this is such a helpful framework, and most of my work again has been focused again in the individual and community levels of influence, and thinking about really where those domains are in terms of behavioral, health system, sociocultural, and then the community influencers or gatekeepers has been really helpful. And then I'll just end by saying that I've done a lot of rethinking of the role of specialists and how we can be allies in eliminating hepatitis B, and rethinking how do we move to non-traditional ways of thinking about our solutions and how we reach communities. And how do we simplify our guidance to increase adoption and adherence? Recognize that there may be training gaps we can help fill. Thinking about how we make care low barrier or low threshold care for communities that have already a lot of barriers. And think about how we advocate, specialists advocating side by side with all stakeholders, I think can be very powerful and being done locally and globally to increase funding and policies to achieve elimination. And with that, I will end with my acknowledgement slide. Thank you.
Thank you. Thank you for that wonderful talk. And I encourage people to send in questions, and we will have these questions addressed during our panel discussion session. And like to move on to our next speaker. We have Dr. Janice So. She's a clinical psychologist and professor of psychiatry and behavioral sciences at the University of California, San Francisco School of Medicine. She's also co-director of the Asian American Research Center on Health. Her topic is Health Within Reach, an interactive video patient education intervention to increase hepatitis B and C screening among Asian Americans in primary care. Dr. So.
Thank you so much, Dr. Das and Dr. Ward and NIMHC for this opportunity to share with you all about our work on hepatitis B and C screening with Asian American at this webinar today. So today we'll share with you the study that focusing on a randomized trial to test an interactive video patient education program called Health Within Reach to increase hepatitis B and C screening among our Asian American patient population in primary care. So I have no disclosures. All right, let's start with some background. And Asian Americans currently constitute 7% of the US population, and the fastest growing racial group in the United States. 2 in 3 Asian Americans are immigrants, and many of whom, more than 40% of the immigrants, do not speak English very well with limited English proficiency. As you have heard from Dr. Paris-Devley mentioning about Asian Americans also as a group having the highest chronic hepatitis B viral infection rates, more than 10 times the rate among non-Hispanic whites, for example, from the data in 2019. And certainly screening among HBV, HCV remains suboptimal. Depending on the studies, oftentimes we see like more than 50% of the population have never been screened. What do we know right now? What are some of the interventions that have shown working in terms of, with the Asian American populations? Here are some examples. First of all, kind of looking at education, working directly with Asian American population. You can see these number of studies here. A lot of them using a community health workers approach, lay health workers approach. Some of them involve home visits. Some of them actually involve church settings, and more intensively involving packaging in like a patient navigation. Some more study here focusing on provider levels, electronic health record-based strategies, alerts to the provider, including our own, just recently published in the Journal of General Internal Medicine, where we involve both patients and provider, and we'll tell you more about it. This table just show really general, like a quick summary, a quick look at just examples of some of these interventions that have been tested, and many of which are relying on self-report, some of those with confirmation from electronic health records as well, or medical health records. And you can see the odds ratio illustrating the intervention effects. They work. They actually did quite well compared comparatively. And you can see there are various intensity level as well. When it comes to electronic health record-based strategies, also we are seeing very positive outcome, particularly with EHR alerts running in between like 2 to 3 times in terms of the odds from like as compared to usual care. And the last line about our intervention also will tell you more details, kind of when we work with both patient education and providers together, we're seeing quite positive outcome there. All right, let's dive into allowing me to tell you more about our intervention, Health Within Reach. It's a multilingual video doctor. We use a lot of focus group talking points, heavy involvement with our stakeholders, both providers and our patient community to develop this application. Available in different languages, English, Cantonese, Chinese, Mandarin Chinese, and Vietnamese. The idea here is to leverage clinical visits where while the patient is waiting to see their primary care provider, they will get to receive this interactive video doctor intervention. The design of our study to test the efficacy of this intervention is to compare the intervention package, which includes the video doctor, which I will tell you a little bit more about, integrated with a provider alert piece, and plus provider panel notification. Actually, this also serves as a control or usual care, or more like enhanced usual care intervention. And we tested it in 2 healthcare settings. A little bit more details, the video doctor, what does it have? It started off with some assessment questions. And then in these assessment questions, we also provided tailored video messages. Some of those contents involve, releases basic education of why is it relevant? What is hepatitis B and C? Why is it relevant to Asian Americans? What does it do? And some of the misconceptualization, perhaps also stigma some people may have. One of the topic that we heard from both our provider side and also a lot of it from our stakeholders, both families and patients, talking about, I'm not necessarily feeling comfortable to ask for the text, to ask for screening. My doctor should know it, So there are also potentially some communication barriers as well. We mentioned about the provider alert, which is at the end of the session. We have the 2 printouts, one for the patient to keep, the other one is for the actual patients to bring it to the doctor for discussion. More of the video clips or the demo of the program, you can see it in the Picori site, and I believe that will be shown on the chat as well as a link that you can go in to take a look. A little bit more details of the provider alert, where example, this is like in multilingual in the language of choice of the patient, and certainly for providers we have in English. And you can see for the patients section is really talking about recommendations or reminders of what they have just seen, some of the key messages. And on the provider side, at the bottom of the alert is really serve as a cue for action, like reminders of the screening. And particularly because we're enrolling only those who had no EHR, no documentation on their medical record about having been screened for hepatitis B. For the control condition, we do an attention control while all the providers receiving their panel notification. For those who randomly assigned to the control group, they also receive video education. Is another app, and it's focusing on nutrition, physical activity, and healthy weight. About our study design, a cluster randomized trial. Randomization took place at the provider level, and patient eligibility. Asian Americans, as actually shown on medical records, but we further asked them, do they identify themselves as Asian Americans, age 18, speaking one of the languages, as I mentioned earlier, English, Cantonese, Mandarin, or Vietnamese, and also have no hepatitis B screening on medical record, and have an upcoming PCP visit. Recruitment, we use multi-pronged approach from telephone all the way to in-person right before the person comes to the visit. Multiple data sources from patient directly, survey data right before the intervention, immediately after the visit with the doctor, and also 3 months later. Primary outcomes looking at screening rates, also tests being ordered from electronic health records 3 months after the intervention. This is just to summarize. Altogether, we have 452 patients in this trial, and they from altogether 122 primary care providers and 270 in the intervention group and 182 patients in the comparison groups. Here are the patient characteristics, pretty diverse sample. Average age is about 57, wide age range, 18 to 93. A lot of them were born outside of the United States, actually from more than 20 countries of origin, and 44% spoke limited English. Before we get into the screening results, I'd like to share with you, did patients like it? Did they like it? 84% said that they liked the hepatitis app very much, to somewhat. Almost 60% of them gave the printout to the providers at the visit. 95% found the printout was helpful for discussing with the provider. I'd like to share with you a couple of pictures. One of the barriers actually before we launched a study, we also talked with our staff, our clinical staff and providers about potential barriers, many of whom would think that, nah, for our older patient, we didn't think it worked. This is actually a picture of an 80-some-year-old patient participant. He had no trouble using the app at all. Here's another picture just to show how much our patient liked it. As an example, this patient actually, while he was going through the app, he was using his phone, taking screenshots of the app and saying that, I want to tell my families and friends about this information. Some results from EHR in terms of orders and receipts of screening, starting off with hepatitis B. You can see the blue bars, they are from the intervention group, those who received the hepatitis B and C video doctor education, plus provider alerts on the site. And then the green bars are the comparison group, receiving the video doctor education on other topics, nutrition, healthy weight, and physical activity. So we can see the rates in terms of tests ordered within 3 months. 44% had the test order, and close to 38% of those have the test completed within 3 months of the intervention, as compared to less than 10% for the control group. For hepatitis C, we also see very encouraging results as well. Almost 40% of them had the test order. Certainly not everybody are appropriate as well, because our eligibility criteria were focusing on a no Hep B screening on medical records. And then 30% of the population had hepatitis C screening done within that 3 months, as compared to under 10% again of the control group. Intervention effects, looking at multivariable models where there are a lot of patient characteristics being controlled. For hepatitis B, with receiving an odds ratio 7.5 times higher the odds as compared to the control group of having the screening test done within 3 months. Even a bit higher of the intervention effects for hepatitis C as well, having tests done 10.5 times higher the odds among those who are eligible for hepatitis C test within 3 months of the intervention. What have we learned? Conclusion: this multilingual mobile application for patient education not only well received by our patients of Asian American descent who spoke those languages that we mentioned, English, Chinese, and Vietnamese, but also it led to increased hepatitis B and C screening. So I listed some references here for the PCORI final research report, as well as the recent publication on hepatitis B outcome, but we are hoping that our hepatitis C paper will be also coming out very soon as well. Leaving you with a few thoughts on recommendations about working with Asian Americans or addressing hepatitis-related health disparities, focusing on screening, leveraging clinical visits with technology, particularly technology designed through a patient-centered approach that can be easily used by minority patients and even among older and those who speak limited English, can greatly increase screening, hepatitis B and C screening among Asian Americans. When it comes to targeted interventions, so keep in mind, Asian Americans is a very diverse population, not only language, culture, there are also evolving needs. So always keep that in mind. Multi-pronged approach or multi-pronged approaches that involve multi-players, stakeholders. Remember, I shared with you about both patients, providers, very important, takes a village to do this in a coordinated, integrated way. Last but not least, I want to acknowledge my team and a number of individuals, both our advisors, our patients, our providers who have contributed so much in this work. And thank you very much.
Thank you, Dr. So, for a fascinating presentation and great results from your intervention. Before we move, I wanted to see if Dr. Persist is available to answer one question that was addressed to him. Are you available, Dr. Olaseo? There's a question on, I believe many countries have had delays in their hepatitis elimination program because of COVID, and how do we bridge this 2-year gap of the COVID-19 pandemic? Any thoughts? Hello?
Hello, I'm here.
Okay.
Can you hear me? No?
Yes. Yes.
Okay. What was the question again, Rena? I was listening, but I'm not monitoring the chat. What does it say?
It just says that delays in their hepatitis elimination programs by 2030. How do we bridge this 2-year gap because of the COVID-19 pandemic?
You know, the data I showed you about 30% immunization is not changed a whole lot in 20 years. Before COVID, after COVID, COVID is an acute stress on the system, and we're now entering a chronic phase. So I don't think that that's a reason to say that would be a reason to be behind. We've been behind for 30, 40 years. And I think that, you know, the efforts like this are hopefully bringing some attention to it, because it is obviously, you know, vaccines effective, you know, C, we can treat C, you know, there's others more focused things like, you know, we can suppress B if you're chronically infected. So that's another strategy. You can screen for liver cancer, and that may be of benefit in very high risk populations. And obviously we have liver transplant and better treatments for liver cancer. So I don't think that should be a major issue, in my opinion. So.
Yeah. Thank you. If I just add on to that quickly to say, I think there's, you know, a lot of good surveys, including some one done by the coalition, showing that there were large declines in vaccination testing and treatment in the immediate months of the pandemic. But many of those programs were covered and are approaching pre-pandemic levels now. But with the challenges that remain that were pointed out by Dr. Perez-Staple. I'm also interested, you know, how have the transformations in health systems created new opportunities to scale up interventions now that we've had more attention paid to vaccination systems, different types of diagnostic strategies that make diagnostics more readily available, and information systems such as disease surveillance, and how could we apply those to a large health problem like hepatitis, and in so doing, strengthen preparedness for pandemics in the future. Thank you.
Thank you. Okay, let's move on to our next speaker, Dr. Barbara Turner, who is the professor of clinical medicine at Keck School of Medicine at the University of Southern California. She is also a practicing general internist and focuses on health disparities research. Her talk is on implementation of a complex primary care intervention to diagnose and treat HCV in low-income Latinx patients. Dr. Turner.
Thanks so much, Dr. Das. I should acknowledge right off the bat that the work that was done for this project was at UT Health San Antonio, and all of this is a Texas-focused study, even though I've moved westward. And I want to tip my hat to a wonderful team there. Let's see, did I share my screen? Yes, here, let me share my screen again because I'm not sure it's moving ahead. Yeah, so I don't have any disclosures other than I work part-time for the American College of Physicians. And I think we've heard this a lot, but I just want to hammer it home a little bit more. As an internist, end-stage liver disease and liver cancer, the one that especially is due to chronic cirrhosis is hepatocellular carcinoma. They really are pretty scary diseases and quite deadly, even though we have more tools. And, you know, the estimates vary a lot depending on which population you're counting, but there are certainly millions in the US who have chronic HCV, and anywhere from 40 to 50% of them don't even know it. It's a really insidious, sneaky disease until it really gets to be more advanced. Unfortunately, most of the people who have this are low income, and their access to these marvelous drugs can be quite threatened without an infrastructure to deal with that. So this project, as I mentioned, was in Texas, and you can see in blue over here, that's San Antonio in the middle. We also partnered with folks in Dallas at UT Southwestern later on in this project, but it's called Stop HCV, hepatocellular carcinoma and HCV. It was really to implement the full spectrum of screening to treatment for chronic HCV, and at the time it was really baby boomers were the focus of the mandate for screening, although now fortunately it's a much broader mandate to screen everybody who's an adult. And it was in 23 primary care practices in 6 healthcare systems in South Texas. Now, these were mostly federally qualified health centers. All of these practices served low-income patients, primarily Medicaid and uninsured. And it was funded by, I've got to tip my hat to CDC and other federal agencies, as well as state agencies that provided the support for this project. Let me just mention one other thing. These practices are in orange here, shows you where their locations are in South Texas. Now, what about South Texas? It is predominantly Latino, Hispanic, Mexican American mostly. 80% in that region, as opposed to well less than 50% in the rest of the state. The other thing is that it is an area where incomes are very low, with a lot of patients, you can see here, living below the federal poverty level for a household, so in the 40,000 range. So these baby boomers, although we aren't focusing on them only for screening now because we're getting a spread of HCV in all age groups, they still represent the vast majority of chronic HCV infections in the US. And a while ago, the estimate was somewhere less than 500,000 Texans had chronic HCV. And look at the map here. You can see where they're concentrated in the black along the southern part of the state. And it kind of parallels when you look at the incidence of liver cancer in Texas. It is, first of all, higher than nearly every other state at 9.3 per 100,000, with 22,000 new cases annually. But in South Texas, it's vastly higher. And you can see here in the red again that the highest incidence of liver cancer is down there in the south of the state. So we used an implementation framework with REAIM to structure this implementation project. It's really looking at how well we could put into place the pieces of the puzzle to screen and then eventually cure HCV. And so it's reach, adoption, implementation, effectiveness, and I'll talk a little bit about maintenance, although I think that's where the rubber meets the road eventually. We've talked a lot about NIMHD's framework, but this is, I think the CBPR, the community-based participatory research goals, are really a wonderful touchstone for us because we wanted to enhance community capacity with this project for projects that we think we hope, and we wind up collaborating with them to make sure it's something that's relevant to them, that could be sustainable. And we especially wanted to translate research findings into these communities that really had not benefited from them. So start out by reaching out to the community. I think all of us today have spoken about that. We went to little towns all over South Texas to have focus groups and surveys with community members and patients. We also spoke with the practices throughout the region. And it's not just the administrators. We really wanted to get the whole team involved in thinking about the priorities and barriers to implementing screening. And it's not just educational initiatives, but also approaches to make all of this less burdensome. And I think that's one of the catch-22s of screening and implementation, is that it can wind up just burdening the practice. And here's a picture of a meeting. And these outreach community events were super important. And it was important that we had materials that were in Spanish and English, easy, attractive to look at, to help people understand this disease, because we've heard about the fact that the community really doesn't, a lot of them haven't heard about hepatitis C, doesn't understand why they should care about it. So we had community health workers. We've already heard about how important they are. And in this case, they were crucial to connecting. They were bilingual Hispanic community health workers who got out there and were very approachable. We had peers who were engaged, as well as our faculty. We got testimonials, people who were diagnosed sort of out of the blue, shocked by it, and then were treated to cure, about that whole journey, so that people could look and listen to that story and hopefully relate to it. The professional education involved a number of PowerPoint presentations and all aspects. I just want to point out down below that alcohol was a big cofactor in this population, in terms of once you've cured HCV, if you don't address that, the fire will continue to burn in the liver. So we really developed a series about not only diagnosing and treating HCV, but also managing some of the other risks. These were given at meals. We brought in nice meals. We gave them CME and CNE. We had to have some carrots to have people attend. And we developed a website, you can see it's here, which pulled together all of these resources and included the bilingual low literacy resources for the community. So these are the phases of the implementation project. And I think you've heard a lot about all the components that you need to implement to really achieve a cure. I'm going to highlight a few. You've heard about them before, about the EMR and opt-out, but I just want to mention a little bit how important they were in our practices, because they varied a lot across them. We did a little work on our own about mobile apps, and the care navigation was beyond important for this population. You can think of them as having huge problems with transportation, large distances to travel, usually have to rely on public transportation. These were a big deal to get people in to be seen. And we'll be talking more about how COVID affects this kind of delivery of care. And then we have a very interesting model for specialist consultation. And eventually on the side here, I just want to mention that the access was through free drugs that you can get through the drug companies if you meet an income criteria. But we didn't just pay attention to treating the HCV. We managed a lot of other comorbidities in this population. And so a cure is a sustained viral response at 12 weeks. But you're not off the hook if you have cirrhosis. You need ongoing monitoring. And that actually worries me in some of these practices where the infrastructure isn't built very well. So we talked about the EMR. What I want to talk about is the problem if you don't have it. So in a number of these practices, they didn't have a flag, you couldn't put in a flag. Sometimes it just took a lot of money, which we didn't have, and sometimes it just couldn't be changed. And occasionally practices actually were still on paper. So you can imagine how cumbersome it is to have a patient come in and have someone on the team take a look in the chart to see if they needed to be screened, and then order it and keep an eye out for the result. One of the workarounds is we collaborated with the big companies that performed lab tests for their population to get the lists of tested patients and results for each clinic, so they could at least have that reference. But it was incredibly cumbersome for some clinics. And then we also wanted to create a registry of patients with chronic HCV. We heard briefly about opt-out. I think that's super important. As an internist, I really don't have time to go through a long la-di-da about why somebody should be screened for hepatitis C. So we had posters we put up all over the practices. The CDC, I've got to tip my hat, had some wonderful ones that we used. And so we could just say, you're a baby boomer. Everybody has to be screened for hepatitis C. Have you had that yet? No, good. I'll put it in, that kind of thing. And then the rest of the explanation is there in the poster. That reflex testing, I think you heard about it briefly, but it means that when you're anti-HCV positive, they take the same blood sample and they do the RNA. Well, we'll show you some data that it's a big problem if you can't do that, because the patient has to come get contacted and come back in for a second blood sample. That's, I think, another big recommendation of an expert panel that's out there in the US trying to think about ways to accelerate this screening. So this mobile app we made was in Spanish and English, and it's built on qualitative studies that we did. Patients were diagnosed with chronic HCV because they were really confused. I mean, the stigma was shocking. They had said, well, my family says I'm not allowed to hug my grandchildren anymore, and I can't use the same silverware. I mean, it was really staggering. So we made sure that we put together an app that explained A, what it was, B, what it meant for your lifestyle, and C, the opportunity for a cure. These specialist teleconference hours, there are other models out there for supporting a PCP and with a specialist, but we decided it needed to be super brief. And so what we came up with is lunchtime case presentations that our PCPs could do from any of the practices. He was just going to set aside the hepatologist this time. And they discussed not only which regimen, but also other clinical issues that probably needed to be addressed along with the treatment. The sad news is, and I just have to say, that we really didn't have much of an option if somebody had already developed liver cancer and they were uninsured. It was a very difficult situation. So here's an example of a case summary. It just shows you the diagnoses, their medications, substance use, all of the relevant labs, the ultrasound. I'm highlighting here that FIB4, which is a wonderful metric, I think, of how advanced the fibrosis is actually a low number here, but this patient actually had a very high number of the HCV quant. So that would have affected his or her treatment. The other thing is we really didn't care at the end about the genotype. So that saved us a lot of money because of the pan-genotypic drugs. So what about effectiveness? This is I think, a very helpful model to think about those pieces. And we published all of this in a paper in the Annals of Internal Medicine about 2.5 years ago. The quantitative measures had to do with screening, but then from there on in, it had to do with the care of the uninsured and whether they got counseled and finished their testing, and the care plan was developed, they got their free drug, they finished it, they got cured. You can imagine there are a lot of steps. Sorry. So this is, I have to orient you to this slide. These are the characteristics overall of everybody across all of those practices. And there were 27,000 people came in over the duration of the study, which varied somewhat across the different practices, but was no shorter than 9 months. So we had 48% of them were screened. This is from 0. We had a baseline of 0 at all these practices. Only screened people. It wasn't really screening. We tested people if they had elevated LFTs, but there was no screening that went on before. The demographics of the population, or these are baby boomers, more women than men, because women are the ones who come in to get primary care. Mostly almost 90% Latino, and 2/3 were uninsured. This is Texas, remember. What I want to show you are the kind of contrasting experience, because this kind of brings to light some of the models that we need to think about. In this best performing practice, 71% of the patients were screened. They had an EMR that could be modified, and it flagged who needed to be screened. The demographics very much, this is really wide in the border, so almost 100% Latino. And this, the worst performance clinic, only tested 20%. And so we started to wonder what was going on here. The demographics are pretty much the same until you come to the uninsured. And in fact, this is a clinic that mostly serves Medicaid. So I don't think that's a big clue, but look at the anti-HCV plus rate here. You can see overall it was 5%. In the clinic that tested almost everybody, it was only 2. It was 19% in this clinic. And then as you go down, you can see the HCV RNA shows that, again, a much higher proportion of these patients had chronic HCV infection, a fairly low proportion of the best performance clinic. These guys were just really looking at patients and screening, I think, on the right, those who they thought were at risk for having had substance use or using needles. This is not the point of screening. And this is actually a sadly and realistically a care cascade that you see with all of these steps of care that are needed. And these are uninsured patients. Remember, they had no coverage for all of this without our grants. So we had 205 that were diagnosed with chronic HCV. Most of them completed staging. Most of these had the consultation done, although part of it was just the logistics of getting all the data together and scheduling. And then not all the patients were recommended to start treatment right away because of some of the other major issues that were going on, like ragingly uncontrolled diabetes or, severe problems with substance use such that they really couldn't even bring them in. Then once we could get to the companies, get the drug, and have the person start it, we had a lot of success. So there are still so many steps in this cascade to try to deal with. So I just want to conclude with some of the challenges, as if I haven't already brought them out, which is these are incredibly busy practices with lots of competing priorities, and federally qualified health centers have as their metrics right now, I looked it up, diabetes control, hypertension control, and low birth weight. HCV is nowhere on the radar for them to try to meet any kind of metric. Sorry. And the other is that there isn't a financial incentive for HCV screening and care. I'm really bothered by the fact that NQF doesn't have one that would really make practices use it as a metric that they would want to meet. The EMR I already mentioned. If you don't have coverage for tests, even screening tests, the uninsured will say, well, how much does it cost me? And then I didn't talk a lot about the care managers, but they were really amazing people who kept with patients, made sure that they solved a lot of their logistical issues to try to get care, treatment, and adhere to the therapy. And as I mentioned, we could get free drug if you were uninsured. At the time of this study, it was worse to be on Medicaid than it was to be uninsured, because on Medicaid, you had all of these problems of, you had to have more advanced fibrosis, you had to have not drinking for 6 months, and they required it to be a specialist if you prescribe the drug. So we had co-signatures. All of this was removed. And I have to say, it may have been in part because we were really partnering with the state throughout these projects. And I think this is really an important advance. So I think most of these are logical, but I want to say that as an internist, if we could figure out how to make this supported, especially in practices that serve low-income patients, without the infrastructure that was supported by the grant, it's very worrisome whether this could continue. And it really takes the belief that the state or the feds need to invest in this population. Unfortunately, this is where chronic HCV resides in this country. So I just want to acknowledge the funders and an enormous team across South Texas of wonderful people who are in the front lines, as well as a team at UT Health San Antonio. The project that I left was taken over by Bertha Penny Flores, and we have this ongoing partnership with UT Southwestern, but it really does take a village. So thank you very much.
Thank you, Dr. Turner. That was, again, a fascinating talk. And before we go into all these questions that are coming in, keep sending us your questions. I'd like to turn it over to Dr. Ward for introducing the panelists that we have, and then we can address these questions. I would advise the speakers to look at the questions on the chat and the Q&A box. Dr. Ward.
You're on mute, John.
Thank you. It's my pleasure to introduce Dr. Zoe Falade-Wulia from Johns Hopkins School of Medicine. Has been working very much with communities in inner city Baltimore, among other activities, and I'll turn it over to her.
Thank you very much, Dr. Ward, and thanks for the opportunity to hear these amazing presentations and share our experience with using patient navigation as a model for hepatitis C care integration into public health clinics in a predominantly African-American community. Next, right now in the US, African-Americans have twice the prevalence of hepatitis C compared to whites. Public health clinics, as we know, serve patients who are poor. And in Baltimore, our public health clinics are very busy clinics where we provide care to over 15,000 patients a year. It's staffed by NPs and PAs under the supervision of a medical director who is an MD. It provides a wide range of services and is a major source of healthcare to our surrounding medically underserved African-American communities. Next. Our model of patient navigation included finding patient navigators that our patients could see themselves in. The navigator was responsible for providing initial information about hepatitis C testing and the possible outcome of testing. They performed the rapid test and began to build a relationship, which they leveraged later on when results came back to link the patient to care. In addition, they did an initial insurance evaluation and provided navigation as needed, transportation, reminder calls, whatever the patient needed to get to their next step of the hepatitis C care continuum. This was so successful that it has since been expanded to a citywide hepatitis C linkage to care service that is now run by disease intervention specialists at the Baltimore City Health Department. Next slide. These are our outcomes. In the first 9 months of implementation, we performed over 2,500 tests. 90% of those tests were in African Americans, 62% were male, and 3% were HIV infected. The overall antibody prevalence was 7%. And I think what's most exciting is that although we were using a rapid test, which required a separate blood draw for HCV RNA was sent to a lab core and results were available 7 days later. With patient navigation, we were able to get 98% of patients to have HCV RNA testing, of which 85% returned to the clinic for their RNA results and initial evaluation of their hepatitis C. When the program was started, we had to refer offsite to specialist care. Even with offsite linkage, 52% of patients attended a specialist appointment. And unfortunately, due to restrictions on access to treatment, only 24% were prescribed hepatitis C medication. Next slide. We learned from that and then integrated hepatitis C treatment into the services being provided in the public health clinic. We have learned about how important it is to simplify treatment. It is now so simple that most providers can effectively treat and cure patients of hepatitis C. Between 2015 and 2019, 560 hepatitis C viremic patients were treated in our public health clinics. 80% of these patients were Black. And you can see that majority of these patients did follow up. If you look at the population that were viremic, 75% came in, 75% were scheduled for evaluation, of which 62% actually attended the appointment. Unfortunately, insurance restrictions remain a barrier to care. That sharp drop you see between F1 and F2 stage of liver disease is because up until 2020 in the state of Maryland, Maryland Medicaid restricted access to hepatitis C treatment for those that had F0 or F1 liver disease, so that every patient that qualified for treatment essentially had access to treatment, of which majority initiated and close to 90% achieved cure. Next, please. And if you focus on patients that sometimes are considered hard to reach, you see that cure rates were high in patients with or without substance use. What was the secret to success? I think the critical components, as many of the other speakers have highlighted, is working with the community you're serving and the setting you're working in to integrate whatever intervention into the setting. In our case, patient navigation was integrated into routine clinic workflow. It was critical that our peer navigator had a basic understanding of hepatitis C, could help the patients understand their hepatitis C test results, and could also convey excitement about care. Our navigators were culturally competent and could communicate in ways that patients understood and appreciated. They had good communication skills and demonstrated care for the population that we were serving. Next slide. That is all I have. I have a couple of questions for the speakers. I know we also have some questions in the chat. I will start with you, Dr. Perumal Swami. So it's exciting that you were able to get into these immigrant communities, and I know that that took trust building. You mentioned that your community health workers were critical to building that trust. How did you do the initial selection of community health workers, which I know was critical to effectiveness of your intervention?
Yeah, thank you. Enjoyed listening to everybody's talk. I think, partnering with the community-based organization that we did, they had a community health worker that was engaged in other activities. So bringing them into what we were developing around viral hepatitis and having them really be a person leading that effort was really the success, I would say, of what we were trying to do. I think as a health system, we don't have good reputations in these communities. Their communities know that you are often out there to get something from them. That's not how you build relationships. So we sat together. And so the community health worker really led a lot of the efforts, helped us develop strategy. Their input was very helpful. They were a trusted person in their community. People knew who he was. And the community organization that he was part of was also very well known. So I think then building on all of that, engaging community leaders, then became also gatekeepers, right? Like they were the people that their community members look to. They're not going to look to us. They're going to look to people in their community that they trust. And so you think about stakeholder engagement and all of these were the key stakeholders to developing this model and really enabled building ties, building trust, and saying we were doing this together. They gave us feedback of what they wanted from us and delivering back and forth on what the requests were and developing ideas and strategies together. Yeah.
That's exciting. Dr. So, I am so excited by your app, and there's nothing like consumer-driven testing. It's amazing. Now, I saw that folks had iPads on their laps in the waiting room. In addition to the iPads, was there any other way that the patients accessed the app? And were there any challenges with accessing the app that you could share with us?
Excellent questions. Actually, this is one version of our video doctors. And then since then, and actually slightly before that, but mostly since then, we have multiple versions of video doctor talking about other topics, but focusing on this study first is that certainly, at the time when when we made the app, we only made it available through the app, mainly because we have a little bit better control in terms of the device. And also the delivery of the video, such that there would be less technical problem once it gets started. But the current versions of the video doctors that our team been doing, focusing on smoking, focusing on physical activity, nutrition, and so on. We have, particularly for smoking, we have it available online as well, because we actually did another pilot trial during the pandemic. And so we moved everything online. And that actually could run into some problem because we have much less control when it comes to individuals, particular patient participants, internet connection. So in terms of like some of the problem, yes, I think actually our clinic staff particularly is like, what if they walk away with the iPad? How to be like the security. And certainly when it comes to this day and age, is really like, who and how and best we could disinfect the devices. And so a part of the situation we try to do, but it's always harder, is that we also make it an option so that if it's preferred by the patient, they can also access it on their phone as well. But sometimes the video, depending on the phone, it may be way too small, as well. So we're still like solving these issues, but we are, at least for the current versions that we're making right now, is that we try to make it multiple, like the iPad when they're on site, and also making it available when they can do it at home. But the key thing is actually to get their attention. If we have them do it at home, many of them, it would be harder for them to do it.
Yeah, your outcomes were amazing.
Yeah, thank you.
Dr. Turner, your intervention is off the chain. It's so complex and so comprehensive. What was the staffing structure required to implement that intervention? And have you been able to sustain some of that?
Yeah. Well, I think there are a number of issues. We couldn't sustain it if we couldn't cover the labs. We were pretty much done if we ended that. We did keep it up. I have to tip my hat to Texas has the CPRIT. It's a cancer research program that they use their tobacco money for, and that has kept this program going. And I have to say that CPRIT had not funded anything to prevent liver cancer until we went up and pleaded along with a number of other experts in the state, and now they've very much embraced it. But that's the thing that gets me about the sustainability. And that's how the conversation needs to go to, HRSA and CMS and the other. I think that's the challenge, is making sure that the care navigation, you and I both feel very strongly about that. These wonderful people followed people through the most remote places in South Texas to keep them in. And so that isn't funded either. So, I sort of skipped the maintenance part because that's where I get tripped up. We do okay because we continue to have funding, but, and the other thing I've got to make a plea for is to really push for this becoming a quality of care metric all over the country. It has to be. You have to be able to get a benefit for saying, okay, I've tested whatever X number of my patients, instead of just sort of making it a, I'm passionate about HCV, so I'll do it. But I think there are a lot of things that we can do from a healthcare delivery organizational side to make this sustainable.
Exactly. And it speaks to what Dr. Pramil Swami had brought up about advocacy, and advocacy to push all these things that will be required, especially if we want to achieve equity for the populations that really need support, both for testing and access to treatment.
Mm-hmm. That's right.
The other thing, if I could just add, you know, I definitely think advocating for the funding on the federal level is really important, but like what we did with our health system, you know, we said we have to put our money where our mouth is. We need this to be hospital funded too, because we're not seeing the federal dollars. So we initially started out grant funded, and we, you know, made a return on investment case and said, look, this improves the health of our neighboring communities. So I also think there's a role for us as providers advocating with, and I know there are limitations depending on where we're practicing and what finances look like, but I do think, I don't know, it took me some time to come into that, but, and it still remains a hospital funded program, our outreach program and our care coordination program. Yeah.
Thank you all. I know we're almost out of time. You know, one aspect that we touched on, but didn't really get much discussion going around is around stigma and around, how people perceive other people who are different by race and ethnicity. And, I've seen some studies that show that, care is delivered better or received better by Black Americans if they have a Black healthcare provider. And I just, I don't want to call it, systemic racism within healthcare systems, but, the way this has been presented, it's almost like it's just any other intervention. But, is stigma and those kind of differences in perceptions based on race, ethnicity from healthcare providers to their patients, is that an issue we need to be aware of in delivering this type of service for these populations?
I actually want to offer a little data about that. So one of the projects we had that I didn't describe here was working with UT Southwestern, not that I want to blame them, and Parkland, but they had a program where primary care practices would just screen for the antibody because they couldn't do the reflex. And then anybody who was antibody positive, they would refer them to hepatology because they couldn't get them in to do the reflex testing. And a very small proportion of the patients, without any education, support, explanation, went on to hepatology, just being told that they were antibody positive. So I think at that point they said, oh yeah, well, we do have to engage the people in understanding what the thing is that they're actually going to address. And I think that's why the app, and I think all of us feel like if we can find efficient ways to help people understand this disease and understand how common it is, and it's wonderful story because it's treatable, and anything that they might have done to get that disease was eons ago because it takes about 20 years to have anything. I mean, there's no stigma anymore, and I think that is an important message.
Yeah.
But I think patients continue to feel stigma, and I think every single intervention that has been presented today indirectly affected stigma, right? You provided information, Dr. Shu, in your intervention that made hepatitis B accessible, right? Dr. Turner, you had community health workers and patient navigators that patients could identify with and trusted enough to make them feel comfortable in this setting. Same thing, Dr. Premolzwami. So I do think stigma is critical that we do need to address if we really are going to move the needle on hepatitis C elimination. And part of that is having a diverse workforce, as was brought up early, right? Where there are providers, right, that look like and patients can identify themselves with. We're having treatment integrated into settings where people already feel comfortable accessing care so that it makes stigma less of an issue.
There's another word which we haven't mentioned, which is fear. And I have a fair number of patients with whom I have discussions about diseases, and they really don't want to hear it. So I think that's another thing that we have to disabuse, that it's, it's pretty scary when you say your liver is quite damaged and you need to continue to have ultrasounds look at it, and offer that hand-holding to get through all of it.
For us, I mean, in part, a lot of the education focusing on, the importance of prevention, but recognizing that we do hear people say, I don't want to find out, I don't want to know, but telling them, hey, we have these really good treatments if you detect it early enough. And then we know that a lot of people actually are asymptomatic, so many of them are not aware. And so that is what we also try try to emphasize as well. Yeah, but we do a lot, actually, more like also language concordant and ethnic concordant video. Even for our video, we actually, have our video doctors in, in Asian, ethnicity and speaking the native language as well as part of the education.
And another big intervention that addresses stigma, honestly, has been the change in the guidelines, right? Because if everybody should be getting a hepatitis test, then you don't feel singled out by your provider. And so you're more likely to be like, yeah, I'll get it because everybody gets it. And even providers may feel more comfortable because then they don't have to explain to the patient why they're recommending a hepatitis test.
Yeah. A key goal of a general population screening recommendation, absolutely. Destigmatization. I know we're over time. Rena, I don't know if you had a last question or otherwise I think we'll need to wrap up. There was an evaluation I would appreciate the participants contributing to, but Rena, I'll turn it over to you.
Thank you. No, I think these were excellent discussion. I think we can probably go on and on this. One thing is, how do you implement these great interventions that you just shared in real world setting? I think that's where we think there's a lot more effort that probably still needs to be done.
Great.
So I'd like to thank everybody for a wonderful discussion, for really stimulating a lot of questions that came out that we couldn't get to. But this is just shining light on this particular problem on the hepatitis disparities. So hopefully people got some nuggets from this talk to see how we can increase our efforts in eliminating them.
Thank you very much. Thanks again to the presenters, all of you. Thanks for participating. Please go to globalhep.org to learn more about the next webinar and about the content of this one. Thank you very much.
Thank you. Bye-bye.
Bye. Bye.
Bye. Thank you.
Great job, everyone. Really enjoyed it.
Thanks so much.
Bye.
Bye.
Thank you so much, everyone. It was a terrific webinar. We really appreciate everyone's participation today. We'll be in touch.